So good morning. We are going to see the second part of infertility, that is the identification of specific causes. So who all needs ovarian reserve testing? It's a continuation of the last video. So ovarian reserve testing is done for patients more than 25 years who have unexplained infertility, who has family history of early menopause, previous ovarian surgery, oophorectomy, unilateral oophorectomy, ovarian drilling, or who has undergone chemotherapy for lymphoma, radiotherapy for some other cancers, has history of smoking, or poor response to exogenous gonadotropins. So what is the goal of infertility management? First, you have to properly evaluate. Second, identify the specific cause. Third, treat the specific cause, meanwhile giving emotional support to the couple. So what is the first step in management is the change in lifestyle factors, because you see all these factors: obesity, high BMI is increased with infertility, and smoking, alcohol causes poor semen and impotence. Caffeine intake more than 200 milligram per day, that is 12 cups per day, is associated with infertility, so you have to stop all these things. Drug addicts, marijuana, it inhibits GnRH release secretion in both males and females. In males it affects spermatogenesis, in females it causes tubal diseases, so all these things should be stopped. So this data is important. Why we have 1 year of unprotected sexual intercourse for the definition of infertility is because within 3 months of exposure 60% get pregnant, within 6 months 70% get pregnant, within 1 year 85% couples get pregnant. And there is one concept called as reproductive efficiency. In a normal fertile couples, the cycle fecundity averages 20%. So in a normal 20-day regular cycle, the probability of having a live birth is 20%, and it does not exceed approximately 35% even when the coitus is carefully timed. So the benchmark for comparison is only 35%, and it is not 100%. So what are the causes of infertility? 40% ovarian, 40% tubal, 10% uterine, and 10% unexplained. So when do we evaluate and why? So we evaluate after 1 year of unprotected intercourse. Also earlier, if the patient is having some criteria like age more than 35 years, irregular cycles, pelvic inflammatory disease, endometriosis, a male partner with poor semen qualities. So all these needs evaluation even at a earlier period, because as the age advances, fertility decreases, and as the duration of infertility increases, the probability of achieving a live birth without treatment decreases. This is a direct statement from SPEROFF. So we do history examination, and then we do screening test. So screening is done for CS cervix because reproductive age group is a risk factor for CS cervix. Second, we do genetic counseling if the couple is a consanguineous marriage, and also we do carrier testing for cystic fibrosis if they have family history, and also we do test for sexually transmitted infections like HIV, VDRL, chlamydia, and gonococci. And then we go for the specific factors, ovarian factors. So the test used to diagnose anovulation, or the test used to assess the effectiveness of treatment as well. So we take history. If it's a regular cycle, that means she's ovulating normally. If it's irregular cycle, ovulation may or may not happen. If it's happening, it is in an inconsistent phase. Basal body temperature 97 to 98% in a follicular phase. After in a ovulation time, it will rise around 0.4 to 0.8 degree Fahrenheit. So daily the women will take the oral temperature and document in her diary. So the day that she notices rise in temperature will be the day that she is getting ovulation. So that will be the period to have sexual intercourse. But this has a drawback. When the patient is having a medroxyprogesterone acetate or norethindrone acetate, and the basal body temperature will be higher throughout in the follicular phase as well, so it's useless. Then next is the serum progesterone levels. So mid-luteal serum progesterone more than 10 is good value, less than 3 indicates anovulation. So normally in a follicular phase it will be 1, around ovulation or around LH surge it will be 2, and around ovulation it increases like 3, 4 like that, and just before menstruation it drops down. So this mid-luteal serum progesterone, this timing is very important. It has very little value only, because it is useful only to document anovulation and not about the quality of the luteal function. And the other thing is urinary LH excretion. LH is a hormone that is secreted from the pituitary, and it has a short half-life, and it is eliminated in the urine. So daily the woman will check the urine LH with this test, ovulation prediction kit or the LH kit. The day that she notices two marks on the kit will be the day that she's having LH surge. So the concept is ovulation happens following LH surge within 14 to 28 hours. So LH surge is noted, then that is the time to have sexual intercourse. Endometrial biopsy. So normally what happens is follicular phase, ovulation, then progesterone comes, secretory phase comes. So in anovulation, there is no progesterone, so the endometrium remains in the proliferative phase and there are no secretory changes. But this test is invasive, painful, and it is not useful nowadays. Last one is transvaginal sonography. Normally the follicles grow at a rate of 1 to 3 mm per day. After ovulation, the follicles will rupture, so the margins of the follicles will be irregular and the echogenicity will be increased. There will be fluid in the cul-de-sac. All these things can be picked up in the ultrasound. When the patient is taking NSAIDs, what happens is there will not be any rupture. So it results in luteinized unruptured follicle. So any women in a reproductive age group wishing to get pregnant should not take NSAIDs. The other factor is cervical factor. Cervix is the place where the interaction happens between the cervical mucus and the sperm, and it helps in transport. So postcoital testing is done after sexual intercourse. The mucus, cervical mucus is taken and it is checked for spin barcating, ferning, this number of sperm count, density, motility. So normally it has to be progressive unidirectional motility. If there is no motility and the sperms are found to be stagnant at one particular point, and that we note a specific sign called as the shaking sperm, then it means that the anti-sperm antibodies are present that prevents the motility of the sperm. So it needs testing, but nowadays these tests is also not done. Then we come for the uterine factors. We have congenital uterine anomalies, that septate uterus, arcuate, bicornate and all. Septate uterus is most frequent anomaly, that is 3%, and it accounts for more fetal loss in the first trimester and second trimester. In first trimester, it impairs the implantation, and second trimester it causes abortion, early fetal loss. So this has resulted in a majority of the that majority means 60% of the first trimester miscarriage is contributed by septate anomaly. Arcuate anomaly is second frequent, but it has little or no fetal loss. In fact, it has good pregnancy outcome. Then myomas, then intrauterine adhesions, Asherman syndrome, endometrial polyps. So endometrial polyps are something that is because of growth, endometrial hyperplasia, endometrial aromatase overexpression. There will be hyperplastic growth with a vascular core and with or without pedicle. It impairs implantation and it impairs the outcome after IUI. So the polypectomy improves fertility. Last one is a chronic endometritis. It can result as a result of recurrent bacterial vaginosis or mucopurulent cervicitis like chlamydia and gonorrhea. All these can further result in tubal infertility. So now we'll see why this myomas are causing infertility. One is because of the mass effect, it causes cervical displacement, so decreased sperm exposure. Second, because of the submucosal fibroid, the cavity is distorted, so there is improper implantation. Third, there is altered vascularity and the pressure effect on the gland causing glandular atrophy. So they are also resulting in poor implantation. Obstruction of the interstitial part, so it prevents fertilization as well, and distorted adnexal anatomy interferes with ovum capture. So this submucosal fibroid myoma reduces the IVF success rate by 70%, and the intramural myoma reduces its success rate by 20 to 40%. Subserosal fibroid does not have any impact at all. So the removal of the fibroid, myomectomy, does improve the fertility rate. If you can see this image, without myomectomy, the fertility rate was 27%. The same patient, after undergoing myomectomy, the fertility rate improved to 43%. If the patient has had submucosal and intramural fibroid, without myomectomy, her fertility rate was 15%. After myomectomy, the fertility rate was 26%. Whereas the myomectomy does not improve the fertility rate for intramural fibroids. So then next factor is a tubal factor. Patient with a history of previous ectopic pregnancy, ruptured appendix, septic abortions, pelvic inflammatory disease, all they have distorted tube pathology, so they will result in tubal infertility. So it can be just anatomically divided into proximal or distal. So proximal segment tubal problems will have problem in sperm transport and putting it into the ampulla and causing fertilization. So the distal part will have problem in ovum capture and fertilization. So the distal part, that can have fimbrial agglutination, fimbrial phimosis, or complete obstruction. So all these things can be diagnosed with the help of hysterosalpingography, that which uses a oil media to diagnose. It has a sensitivity of 94% and specificity of 92%. It is cheap. It is done as OPD procedure, but it has a drawback. It can cause anaphylaxis because of the oil media. Second thing is laparoscopy. That is a gold standard procedure, because during the procedure, if you find any adhesions, you can do adhesiolysis on the same sitting. If you find any fimbrial agglutination, fibroplasty can be done. Third thing is sonohysterosalpingography. It is similar to hysterosalpingography except that it uses saline and ultrasound guidance. So it has sensitivity of 92% and specificity of 95%. Hycosy is hysterosalpingo contrast sonography that uses glycerol and hydroxyethyl cellulose as a media. And the last one is chlamydia antibody test. It's done in cases where the PID is suspected. So what is the role of tubal surgery in this era of ART? We have three kind of surgeries, like sterilization reversal, distal tubal occlusion repair, and proximal tubal occlusion repair. So microsterilization reversal, the outcome depends on the age, the final length of the tube attained, and the number of children desired by the mother. So ideally, if you see any young patient with no other history of infertility or no other history of other factors of infertility, desiring one live child is ideal candidate for sterilization reversal. Distal tubal occlusion, like patient having hydrosalpinges or any issue or like the coil-like thing that gets fixed in the fallopian tube, fibrosis all has happened. You can do laparoscopic surgery, excision, and neosalpingostomy. Proximal tubal occlusion, like debris or spasm, all these can be overcome with the help of laparoscopy or with the help of hysteroscopy. Last point is about unexplained infertility. We define unexplained infertility in cases where the seminal is normal, the female is having normal ovulation and the uterine cavity, at least one tube is patent. And the points like postcoital test and endometrial biopsy are no longer required for the diagnosis. So cervical factors and the luteal phase defect are not included in the diagnosis of unexplained infertility. So the treatment is clomiphene citrate plus IUI. We have a trial called as FAST trial, that is fast track and standard treatment trial, where they grouped the people into two. One group received clomiphene citrate and IUI for 3 cycles, followed by IVF for 6 cycles. The other group received clomiphene citrate and IUI for 3 cycles, followed by gonadotrophins for 3 cycles, and then IVF. So then they compared the per cycle pregnancy rate. It was 7.6 for clomiphene citrate plus IUI, 30% for IVF, and 9.8 for gonadotrophins. Though the number is less when compared with IVF, it does have some positive impact on the fertility rate, so it is recommended for patients with unexplained infertility. Whereas simply IUI in natural cycle has no clinically important effects. IUI alone is not done for unexplained infertility. You have to combine it with clomiphene citrate. I hope it helps. Thank you.